And even when we need to do vaginal scans, transvaginal scans, we would note that for transvaginal scans, it's almost like an extension of the clinical examination and is widely available. There's hardly any city or town within this country where you would not find ultrasound. And in comparison to other investigative modalities, it's relatively affordable. One ultrasound, you may take maybe 100 ultrasounds or 10 ultrasounds to be able to pay for maybe one CT scan. And the real-time imaging capabilities are important for guided procedures. You can do things like needle aspirations and biopsies under ultrasound guidance. An important thing again is that ultrasound um, has no radiation, is harmless for the patient and the physician. So it also cuts costs. If you're setting up X-ray, you have to talk about lead protection, lead aprons, and all of that. But we don't have that with ultrasound. And then you also have portable machines that can enable us have point of care ultrasound. With all these advantages, however, we notice that ultrasound is operator dependent. The more experienced you are, the better you become. You may get the latest equipment today, but if you don't have the requisite training and experience, you may lose out on important things. And then it can be affected by the body habitus, and then certain organs that contain air can be difficult to visualize. So I know you've had lectures already on physics, so I'm not going to say anything about this. Just stating again that ultrasound, uses waves and their echoes to generate images. And we can see here we have infrasound, we have the audible frequencies, and we have ultrasound. That's the realm of the dolphins and the bats. And even though you've had the lectures on physics, it's important to note that sound wave, travels through soft tissues at certain velocities. And if you look at the frequency and the wavelength, it tells us that as frequency increases, resolution improves with reduced penetration. This is important because eventually, when we're doing scans, how we utilize our equipment, when we look at the patient's maybe body habitus, it will tell us what kind of transducer to use, what settings to use. And then it's important to also know that as frequency decreases, resolution reduces with increased tissue penetration. So there's this inverse relationship. This is just a note to show the various parts of an ultrasound machine. And one of the things that's most important is this. You may see me moving my cursor around this. This is a transvaginal probe, and then this is a curvilinear transabdominal probe. This is an important part of the machine that you have to guard with all you can. So I had said earlier that we have transducers. This is a convex transducer, and we see that it has different frequencies. So based on what I had said earlier, it means that this transducer would give us better penetration than one that has a higher frequency here. But the image quality would be the inverse of that. So these are basic terminology utilized in ultrasound. I believe this may have been taken when you had the lecture about the basics. Echogenicity is actually the ability of a structure to return reflected ultrasound waves. So basically, if we say something is anechoic, it means it appears completely black on ultrasound, no returning echoes. Hyperechoic, highly reflective tissue with stronger returning echoes. You can see that as whitish or more whitish. Hypoechoic, less reflective. And then we can see isoechoic. So basically, this is how this looks. So anechoic would look black like this. Hypoechoic, so you can see different shades of gray. All right. So having set that basic foundation, remember that this topic is actually an introduction to gynae ultrasound because we can't take everything at one sitting. We have the basic training, we have intermediate training, we have advanced and subspecialty training. These are all types of trainings that you can have in gynae ultrasound. And the more advanced you are, the better you can become. We can see that competency-based characterization or categorization, if you are started out to scan and you're a level 1 scanner, it means that we expect you to perform at least 300 exams under supervision. And then you have to do at least 300 exams each year to maintain your status as a baseline sonographer. If you go to level 2, you should have undertaken at least 2,000 ultrasounds. And then you would be required to perform at least 500 exams each year to maintain competence. And then for you to become an expert, people like Prof. Higa, you need majority of your time actually spent undertaking ultrasound, teaching and doing research in this field. So basically, we have said it's important to get equipment. It's good to get training. So in summary, we just want to state that the quality of ultrasound imaging relies on the 3 T's: the technician, technology, and the technique. Technician is you who is being trained at the moment, learning properly and being able to utilize the information to carry out good scans. The technology is the equipment you have and your ability to utilize it. And then the technique is actually following laid down on standard SOPs on how to do ultrasound properly. So you need to be appropriately trained and appropriately resourced and work within your level of competence. So since we're talking about gynae exams, actually, how should we do these exams? The standard pelvic exam, we could do the traditional transabdominal approach, or we can do the transvaginal sonography, and we may utilize Doppler when necessary. And one thing that is important to note is that you must ensure respect for the client as well as adequate privacy, especially when you may need to do internal exams. Ensure you get consent before you proceed. Now, most of us may have seen transabdominal scans. With this, you actually need the woman to take water, have a distended bladder, and this will serve as an acoustic window so that you can see pelvic structures. And then you may do a transvaginal scan. The beauty with this is that the patient does not need a full bladder. So we have 2 images here. You can see this image is for transabdominal sonography. You can see the window that the bladder gives, see the uterus, the cervix, the vagina. And then this is the same image, but in a transverse view. In a transverse view. This exactly is what we can see. Then, if we look, the next image, this is the image for transvaginal ultrasound, and you can see how close the transducer gets to the cervix. So you would have clearer images, and you would see this is also a transverse view. This is a transverse view for a transvaginal ultrasound scan. So, which is preferred? Both can be utilized, but then consensus is that if with the requisite training, actually a transvaginal approach with superb resolution and closer proximity to the pelvis is actually preferred. But again, I must emphasize good respect for the client and ensuring you've got an informed consent. And when a transvaginal ultrasound is inappropriate, like in the case where you have a virgin, you may need a transrectal scan if you need some specific information. Okay, so since we're talking about introduction to gynae ultrasound, actually, what should someone who has basic to intermediate knowledge be able to do? One of the first things is that you should be able to assess normal anatomy because that's actually the starting point. There are times you may not know that something is abnormal, but once you know this, what I can see here is normal. This doesn't look normal. You're able to say, okay, how can I find out what is wrong with the image? You should be able to know at least basic things like fibroids, know how to identify adenomyosis. You should be able to, um, identify polycystic ovaries, adnexal masses, and maybe screen for some basic malignancies. So let's look at normal anatomy of the uterus. And I'm going to focus on the ISWOG basic training guidelines because it's very simple way to carry out these scans. So this is just an overview of the basic training program by ISWOG. You can just get more information. I'm sure Dr. Ajayi can give us more information if we want. Now, abdominal gynae ultrasound exams, we could see that on a longitudinal scan, basically, when you put your probe, the left of the screen is the patient's head, and then the right is the patient's feet. And then this green is actually when you will see called the probe marker. You normally see maybe the model of the ultrasound machine here. So you can see what is here, where my cursor is anterior, and this is posterior. So remember, this is superior, inferior, anterior, posterior. So in this image, we have the bladder, and then uterus, cervix, and the vagina. This is a longitudinal scan. And to get a longitudinal image, you hold the transducer with the probe marker. You notice, you may not see, but the probe marker is actually facing the direction of the shoulder of the patient. So these are both longitudinal or sagittal scans of the uterus. So for a transverse scan, you would actually need to rotate the transducer by 90 degrees, such that with the probe marker here, you have anterior, posterior. What changes is that what was superior on the sagittal view becomes the patient's right, and this becomes the patient's left. So it's important to know this so that you don't mislabel when you get to see pathologies. Again, this is another example of a transverse scan through the uterus. In this case, you can see that in this case, the transducer is not straight up as it was. Transverse 90 degrees, the probe marker is here. It's not identified, but normally faces the side of the patient. So, vaginal scans, like we said, can be done, and these vaginal scans can affect the quality of the image because of the proximity. Now, you're doing a vaginal, there are different things again that can be seen. The orientation is important. Generally, with the probe marker here, you can see the way the uterus looks. Some people scan upside down like this, but most times by convention, I notice most of us scan like this. So when we're doing ultrasounds, we have some basic probe movements. We have, when you're doing a transvaginal scan, you have anterior movements, posterior movements, and then movements in the sagittal plane, movements in the transverse plane, and in both planes. All I can say is that when we're doing practical training, we'll be able to learn this more. Something that we must do is that ensure you're gentle, so that once you're doing, a patient should not be screaming in pain. And after getting a good image of the uterus, consensus on measurements. See a sagittal image, you would measure the total length of the uterus, get the anterior posterior diameter, and then you can get the transverse measurement. So again, let's assume you're doing a scan for a woman who probably may have an incomplete abortion. You're doing the scan, you want to see, okay, is the uterus antiverted, retroverted, antiflex, retroflex? This gives you information on how to manage the patient. Now, this is what an antiverted uterus looks like on transvaginal scan. Antiverted, forward facing. Retroverted is facing towards the rectum. And then one thing that is important to note for a normal ultrasound, the endometrium is going to be different depending on the phase of the menstrual cycle. Shortly after menstruation, you see it is thin, early proliferative phase. You can actually see that in different phases of the menstrual cycle, the uterus looks different. So this is just a few seconds. I did this scan yesterday, just so that we'll see this is a transvaginal scan. This is the probe marker I was talking about. So what I'm doing is I'm panning from side to side. You see one of the ovaries came in view. So this is the uterus back, mid-sagittal. I'm moving the uterus. This is now the left side. Again, we can see the uterus back in mid-sagittal. Rotated the transducer. This is transverse. You can see the endometrial plate. And then I gently just rock from side to side. At this point, I want to see the fundus. So I go and you can see the ovaries here just coming into view. Sorry, this is a short video. It's actually quite fast, but I just wanted to show us an example. So we can see various pathologies with ultrasound. A lot of these pathologies, the more you see, the better you become because it's by pattern recognition. So we have fibroids identified in this image. You can see different sizes of fibroids. This is a 3D rendering. You could see fibroids at different parts of the uterus. So if you're starting out, your goal will not even to be doing 3D, would be to focus on the basics of the 2D, and you're able to identify and map the fibroids using the FIGO convention. I'm not sure I have time for this, but this is a scan I did. I just instilled saline into the uterine cavity in order to identify a polyp, a uterine polyp. This is what it is. And then at the end of the day, is what it looks like on 3D. So you should be able to identify adenomyosis. I'm going to hurry up because my time is running fast. We should be able to identify adenomyosis. After taking the history, maybe menstrual pain, there may be infertility, see globular shaped uterus, linear hypoechoic striations. If you look closely, you can actually see that there are different signs. This is from the Musa consensus paper. There are different features you look to see and know whether a patient has adenomyosis. There are direct and indirect features. You can always check these papers out on eSWOG. So this is an example. You can see a normal uterus here, see good endometrium, see the myometrium. With adenomyosis, you see there's complete loss of the junctional zone here. So this endometrium, you can find it everywhere. So again, 3D is not where you should be starting out for. If you see a globular uterus, you should begin to raise suspicion, especially if you have history suggestive. So what about the adnexal? One of the key things to do is to be able to measure the ovaries in 3 dimensions, identify the total length of the ovary, AP measurement, transverse measurements, and you may be able to do a volume of the ovary. Now, scanning the ovaries, I want to tell you that may be very difficult when you start scanning, especially when there's a lot of gas, but don't give up. Preferably, over time, you would learn to use transvaginal sonography. So this is just an example of a scan showing the ovary. You can see multiple follicles within the ovary. You can even see the cumulus oporus over here. All right. So again, very important, when you start scanning, please don't see physiologic, just see physiologic cysts in quotes. These are follicles. Don't just say, this patient has a cyst, 3 cm cyst. You see a lot of patients are being sent 4 cm cyst. The woman begins to panic, and you may just be seeing her about to ovulate. So we must know physiologic cysts. Now, over time, you will learn to identify this what the ovary, how it looks like in polycystic ovaries, PCOS. You can see the increased stromal thickness. You can see multiple follicles around there. So this is just quickly pattern recognition. You're able to identify. Just by looking at this, I deliberately wrote an ovarian cyst, but if I'm actually reporting this, I'll report this as a serous cystadenoma because you're able to report not just that, okay, it's an ovarian cyst. Based on the IOTA nomenclature, you can actually see and say, okay, this is a specific kind of cyst. We don't believe in saying simple cyst or complex ovarian cyst anymore. That is not allowed in our parlance. You know, at this point, what we're able to do is to say, we describe the cyst, and this is a serous cystadenoma. Just by looking at this again, you could see this patient has um, cyst in both ovaries. This is a transvaginal image. You could see ground glass echoes, and these ovaries are kissing in the middle. This actually was an image from a 19-year-old girl who had advanced endometriosis. So these are endometriomas. You could see hemorrhagic cysts, and they may have different manifestations. You could see this lace-like spider web appearance, or you may see it appear like this when you have the clots having retracted. So these are different things you can see. Hemorrhagic cyst, and sometimes this may be physiologic. You would see again other kind of cysts that may be dermoid cysts, and these may show some features like somebody said this looks like akara in oil, akara ball sign, or the truffle sign. So over time, the reason I'm showing these images is that you become better by recognizing the patterns. Pattern recognition is a dermoid, what a dermoid cyst looks like. These are other variations of how this may look like. Now, so this image actually shows that by pattern recognition, if you look at a cyst, you can tell I've shown you about a hemorrhagic cyst. Okay, how does it look? Based on the size, you see a retracting clot. I've shown you like a dermoid cyst. Most of these benign cysts are less than 10 cm. Can see an endometrioma, para-ovarian cyst can be seen, and then peritoneal inclusion cyst can be seen, and then we can also see hydrosalpinges. And then when you see a cyst based on the IOTA group, IOTA stands for International Ovarian Tumor Analysis Group, we can actually tell, is this cyst most likely benign or malignant? And we are able to at least have an idea based on the history, exam features to know what exactly we're dealing with. One of the things, again, that is important that you should be able to know is at least the identification of an ectopic pregnancy. So I saw this patient, when was that? 25th of November last year. This was a transverse view, transvaginal scan, and you would see the uterus was here. we have a left ectopic gestation here. You can see a gestational sac with a yolk sac inside in the left adnexal. So this again is utilizing color Doppler. You see what we call the characteristic ring of fire. You know, I stated earlier that color Doppler can come important. So seeing an ectopic pregnancy um, is something that is life-saving and we should look out for. So basically, I've talked about you should be able to identify normal anatomy of the uterus and adnexa. I've talked about you being able to see, okay, this is physiology, this is pathology. And then just to whet your appetite a little more, can we actually do more with gynae ultrasound? So with advanced gynae ultrasound, we're able to do a detailed assessment of the female pelvis. You do an ultrasound performed by an appropriately trained specialist. And the information we get, we use it to improve patient counseling and plan appropriate treatments. And this is actually because we have improvement in equipment and emergence of specialists with interest in gynae ultrasound. So for example, with advanced ultrasound, you can actually look at the fallopian tubes with ultrasound. And this is something we get to do a lot in our center here. You know, you can do saline installation to evaluate the tubes. You can use gel foam to do that. And you can look at the ovarian function, not just the ovarian structure. And you're able to even assess the pelvis for endometriosis. So if you look at this is actually tubal patency demonstrated with ultrasound. This, you can see how the gel goes in, and you can see how it fills the fallopian tube. So this is something, you're looking at this, and this is not as painful as the routine HSG. So with the right equipment, you can see the spillage of the gel. Again, other things we can do, we can evaluate uterine anomalies. Studies have shown that MRI, ultrasound is as accurate as MRI in the identification of uterine anomalies. So, and this is 3D ultrasound. So for a fraction of the price of an MRI, you're able to identify this. Other things, this is a displaced IUD. You can see the arm of the IUD out here. Is almost towards the cervix. I have another one here where you see the IUD is upside down. So this is displaced. So a patient may have an IUD inserted complaining of abdominal pain, but these may be the things you'll see. Also, just to whet your appetite, pelvic floor ultrasound is something that can be done over time, where you're looking for at women, maybe women who may have things like some incontinence and some other pelvic floor abnormalities, perineal tears, for example. This is a patient I saw. If you look at this red, this is post-delivery. This patient presented with incontinence of flatus. If you look at this red component, this is the levator inner here. This is it here. Look here. This is your transverse perineal muscle. You can see here. So what this patient had, if you look here, you see this is complete. But with pelvic ultrasound, we identified that she had a tear here where the levator inner attached to the transverse perineal muscle. So this is 3D ultrasound, and we're able to go understanding where exactly this defect was and fixed it for her. Again, this is what pelvic ultrasound can show you. So just quickly, this is a video. We have over here, I'm showing you this is a video of how endometriosis. See the uterus is moving completely, question mark endometrium. You can see an endometrioma over there. And you would see that the uterus and the ovary moves as a whole. no sliding in the posterior fornix. I know this is advanced, but I'm just showing us the potential with what we can do. Before now, all we thought was that endometriosis came only via a lap and die, but ultrasound in the right hands can be seen. We can utilize it to see. So in conclusion, ultrasound is at the center of many decisions in gynecology. Ultrasonography is a user-dependent technique which requires training, good experience, and a good quality ultrasound machine. And then the best way to learn ultrasound is to make the diagnosis. And if you can, reinforce the findings by being present at surgery. Thank you very much, Teju. I think I've been able to save about 5 minutes for you.
Yes,
So I'm done with my presentation. Thank you.
so very much. That was a dynamic lecture. Thank you very much. I enjoyed the lecture, the videos, it was engaging. And thank you for
Thank you.
thank you very much, sir. And thank you also for sticking to the stipulated duration. I'm sure that a good number of us have listened in. We have our
Thank you.
questions. Please note your questions. We'll take it at the end of the second lecture.